Start the next stage of your education with us. On behalf of the World Kidney Academy, we welcome you to the CKD-MBD program, a unique international flagship, 12 weeks online program, 2 modules, 20 credit each, weekly lectures, webinars, journal clubs, MCQ and clinical case scenarios, accredited by the American Association of Continuing Medical Education. Take your career to the next level and register now.
Welcome to the CKD-MBD Graduate Certificate Program. This is a unique flagship international program offered wholly online. It's structured as 2 modules, 20 credits each. We are pleased that you have chosen to start the next stage of your education with us. This is a massive investment that will improve your knowledge and clinical practice in the CKD-MBD area. The total number of scheduled learning and teaching hours is 40 hours per module, or 12 hours of directed student activity and 28 hours of student self-directed learning activity. The student is expected to spend 16 to 17 hours of studying per topic over the 12 weeks of the module. Additional time is provided to guide the students during the assessment. Our materials will be issued in a cycle every 7 days. Emphasis will be placed upon developing effective clinical reasoning strategies based upon the use of best evidence and critical reflection of practice. Students are encouraged to submit their work for presentations in national and international conferences and also publish it in peer-reviewed journals. We also support our students' applications for international grants to support advanced nephrology training. The program requires the participants to take ownership of their studies and requires highly motivated, autonomous students, particularly given the challenges in maintaining a work-life balance and international study in some cases. Additionally, given this program is delivered wholly online, participants are expected to engage and contribute to the activities in each 7-day cycle. Therefore, excellent skills and time management are important. But rest assured that the program academic, clinical, and professional services staff is here to support you. We will be working collaboratively to ensure optimal student experience. If you have any questions, concerns, or problems, then please raise them at an early stage with the module leader and the program director. We sincerely hope that you will enjoy your time studying with us and wish you every success.
Hello, everyone. We are going to start our CKD-MBD Module 2 induction meeting. And I'm very glad that we successfully finished the Module 1. Module 2 is supposed to start July 1st. So we still have 9 days to start the CKD-MBD Module 2. As you see, we have our agenda today. Hopefully, we are going to finish within 1 hour. We are going to give you some introduction about the CKD-MBD Module 2 Graduate Certificate Program. Then I will show you the handbook. We'll talk about the World Kidney Academy. We'll give you examples of the composition of our Module 2, including the recorded lectures, including the MCQs, the clinical case scenarios, and journal clubs. We'll show you the platform, then we'll open the floor for questions and answers. Also, you will have a chance to hear from the program directors and co-directors and academic leads. Why CKD-MBD? Why we are very concerned and interested in teaching the CKD-MBD? Because there is a huge management gap. There is no consensus and consistency in CKD-MBD management, and it's one of the devastating diseases that increase our patient mortality. So we are hoping to have a better precise management for the CKD-MBD, and we are planning to have more experts in this field. So when you graduate this program, including Module 1 and Module 2, hopefully you will be an expert in this field, especially in the developing countries. I have a chance to meet and visit several developing countries, and this disease actually is very, very uncontrolled and is a leading cause of death in many of our developing countries, and especially in dialysis patients. Why 2 modules, and each module is 12 weeks? So there is a lot of educational material, and this is real education, not only a webinar or seminar that you can hear or not hear, but we are aiming to teach you and to have a dialogue rather than a monologue with the students, with a lot of tasks, assignments, and a lot of questions and answers and active participations from the students. We are going to help you to understand how to critically appraise and think about the CKD-MBD cases, not only about the bone disease, but also about cardiovascular calcification, about mineral disorders, including magnesium, phosphorus, and calcium. It's a wholly online graduate certificate program that will establish peer support and learning via discussion group and video conferencing. And you will learn things from us as well as from each other, as well as also we are going to learn from you. This program is the first of its kind that deliver basic and advanced knowledge, not only knowledge, but also practice in CKD-MBD, and it's accredited by the American Association of Continuous Medical Education. All scientific materials will be released every Saturday at 8 a.m. Cairo time, and you will have the freedom to navigate throughout the platform and complete the scientific materials and answer and finish your tasks and assignments throughout the whole week. Then by the end of every week, Friday midnight, Cairo time, you need to finish your assignments and turn in your tasks. As you can see here, the CKD-MBD Module 2 will be focusing on osteoporosis management, post-transplant bone disease, cardiovascular calcification, radiology, and guidelines, the key DIGO guidelines for clinical practice management of the CKD-MBD. As you can see here in Module 2, we have 14 participants from 14 countries. We have participants from Africa, Asia, and Europe, 3 countries in Europe, and 6 countries in Asia, and 5 countries in Africa. So we have diversity and participation from most of the continents and different countries and different backgrounds. Here are the participants who passed Module 1. Hopefully, some of you will see their names. So congratulations that you made it to Module 2. And by the end of Module 2, you will receive the American Association of CME accredited certificate for finalizing and finishing the program. We are giving some discount and actually full scholarship, 100% sponsored scholarship, especially to the very poor countries or countries with very low income, as you can see here. So we are helping to establish this practice and to teach students and participants, especially from the third world country. Please make sure to read and learn from questions and answer all the scientific material. The target and the aim for that is to learn. It's not to examine or evaluate you. It's actually to help you to understand, especially to learn the mechanism behind the pathology. It's not only how to treat it or how to diagnose it, but to dig deeper in understanding the disease pathology that will help you to precisely and accurately and properly treat your patient. Try to read also other students and tutor comments and answer, because it's also part of the learning material. So it's open for every student. All your activities and assignments will be monitored. in the platform. So your engagement, we are going to evaluate you not only based on your knowledge, but also based on your engagement and activities in the program. And as you know, that knowledge is of no value unless you put it into practice. And the great aim of education is not the knowledge, but the action to help your patients. So this is the first section of today's meeting. Then here, I'm going to show you the World Kidney Academy web page. It's very important to familiarize yourself with this academy. World Kidney Academy is non-commercial organization conceptualized and developed by professionals with proven credentials in education through distance learning. So e-learning, it's delivered through an interactive platform, which is very advanced electronic platform to enable evidence-based, cost-effective medicine approach for teaching of different kinds of kidney disease. I'm not going to spend a lot of time because I know that we are limited to 1 hour in our induction meeting today. So you can read the mission and vision and the values. You can go over this. The World Kidney Academy actually offers several programs: fellowship in clinical transplantation, fellowship in scientific writing, the CKD-MBD certificate program, fellowship in clinical nephrology, dialysis, and transplantation for allied healthcare professionals. And actually, part of this education is free. As you see, like this disease donor transplantation workshop, it's free. So you can participate either in the commercial or non-commercial part of these activities. So the president of the society of the academy is Dr. Ahmed Halawa from UK, and I'm the vice president of the academy. And ICOM is the company who runs the IT and administration part of this academy. So here you can see the announcement about our program. So all activities you can, if you want to follow or to register and apply, you will receive announcement and information. So you can go here to the registration and register. You can contact us. So it's very important because the CKD-MBD program is part of the activities that are offered by the World Kidney Academy. I'm going to give a chance to our academic lead and associate program directors to share some information with you. So if Dr. Rasha Samir or Dr. Faisal Shaheen, or we have also some of our co-director, Dr. Mohsen El-Qosi, the academic director, if they want to share with you guys some of their experience and some of their feedback, they are welcome to join.
Thank you, Dr. Amr, for I am Dr. Shaheen, and I'm happy to join you today. And really, it is an excellent program which will help our new graduate and also the nephrologists to know about very important subject, which is CKD-MBD, and also the academy. If we combine both together, this is again very advantage point for any nephrologist during his practice. It is a lot of work which you did and your colleague, and I appreciate and all what you did, and I hope that this will return back on the knowledge of our colleague from different places in the world. Thank you again, Amr, for this excellent work.
Thank you so much, Dr. Faisal Shaheen, for these nice words. Dr. Mohsen Kosi.
Thank you very much, Professor Amr. I'm very, very happy and very pleased with this program, to be honest. And probably the students or the predecessors of this program will be the best assessors of the program, who can they give their feedback to say what they have learned, what is the difference between themselves prior to join this program and after they have finished this program, the first module. I'm sure that they will give a lot of positive feedback, which will enable the others to get their experience and about what they have gained throughout the the contribution of the program. I hope that they give us and give the other participants a feedback to give them what they have learned during this course. I'm sure that we are all desperate, whether they are
هذه سمعت أسئلة وأنا الهاتف الكريم مقفول وبين الإدارة اللي فوق.
I'm not sure whether you have heard me at all or I have been muted.
Yeah, we did. Just the last 10 seconds, we lost you.
Okay, no, it is automatically muted. But anyway, the bottom line is, I'm sure that the best assessor will be the participants and the candidates of the first module. They can give the others what they have learned during their this course.
Thank you so much, Dr. Mohsen Kosi, for these nice words and for your contribution in this program. As you see here in the screen, so the CKD-MBD Grad Certificate Program, this is a platform. I know that most of you are familiar with this platform because you already contributed to Module 1. Some are new because they joined in Module 2. As you see here is the announcement that to pass the course, you need to get 70% of, at least 70% of the contribution of all week tasks and assignments. And you need also to get at least 50% pass mark for the final assignments. So that's important. Then when you click on, there is different tasks here. Here you can see the speakers in Module 2. We have speakers from USA, speakers from Britain, from France, several international speakers. You will have also a chance to talk and to communicate and cooperate with our tutors. As you see here, we have 8 tutors, so they are going to be in contacts with you throughout the course. Here is some academic supporting resources that you can go over if you have time and interest. And let's focus on the CKD-MBD Module 2. As you can see here, we uploaded the first 2 weeks. Here is week 1 and week 2, just as a demo. So here is week 1 that's going to start Saturday, July 1st. So just in 9 days, you will have your username and password to the platform. Then you go to week 1, you can see week 1. Then you see the lecture. Then you can hear.
Hello, everybody. I'm pleased to be with you here today to speak to you about one of the important topics in osteoporosis. Its importance comes from, if we know the basics, we will understand what's next. So today I'll speak to you very briefly about an introduction for osteoporosis, then we'll go for definition and how we diagnose the patients and on what base we are going to treat our patients. One of the important points to consider before we go ahead is that our bones are living organs in our bodies. Therefore, we have to be keen on having healthy bone at every age. not only at every age, but also at every stage. Some people may have diseases, may take medications that can affect their bone health. Therefore, it's very important that we consider the bone health at every stage.
So, you need to listen and to learn from these recorded lectures. Then after you listen to the recorded lecture, you go and do your assignments. There is MCQs, there is articles in the journal club section, then there is one or more of the clinical case scenarios. Here is the MCQs. I'll give you just an example. So you'll see 5 to 6 at least MCQs every week. So you start the quiz here, then you see the questions, then you answer them, then there is an automatic reply, and score tells you your right and wrong answer and the rationale and explanation of the right answer. Here is a journal club that include at least one or more of the article that you need to read and to answer every week. Sometimes, like this week, has only one journal. This is a very, very important article. It's European consensus statement on diagnosis and the management of osteoporosis in CKD-MBD. So you can read the article, you can actually download it from here, then read it at your, save it in your desktop, read it at your earliest convenience, then come up and answer. In this bar, you'll see there are several questions here. Can you comment on the WHO and NIH and operational definition of osteoporosis? Can you please explain underlying mechanisms, describe controversial action of BTH, illustrate why peripheral fractures are common, identify risk factor, appraise DEXA and the BMD evaluation, illustrate the reasonable time for osteoporosis screening, talk about vertebral fracture assessment, and TBS and the FRAX score. All of these questions, you will learn how to answer and how to understand it from the article. Then you can add your response here. Then our tutors and the teacher are going to score and to evaluate this. Again, the aim of this is to learn. It's not evaluation, but it's an educational material to help you to get the best knowledge from these. So this is the clinical case scenarios. We talked about MCQs and clinical case scenarios. I showed you the recorded lectures and the journal. And so you can see here, there is 2 clinical case scenarios. The clinical case scenarios is different from the MCQs because it gives you a real case that, give you some information about the clinical presentation, the laboratory and radiological investigation, and it asks you some questions. Then after you answer, it takes you to a next stage of this patient, the response to treatment, the diagnostic results and how to deal with it. So it's a different station and it's open-ended questions. So it's not like MCQ that gives you the best answer out of 4 or 5 answers, but it gives you an open bar that you can add your answer and explanation. I will give a chance to our tutors to give you an illustration about their bars. So we'll start with Dr. Rasha Samir. She is going to give you illustration about the MCQ part, how to learn throughout the course from this MCQ, how to answer and how to get the rationale of the best answer.
Hello everyone, can you hear my voice? My voice clear?
Can you hear me okay, Rasha?
So can you hear me?
Yes, I can hear you very well now.
Okay. Hello everyone, this is Rasha Shmais, Assistant Professor of Metrology, Moscow University. Here I'm going to present a sample of multiple choice questions to test your knowledge in the field of CKD-MBD. So let's start with the first question. Which of the following statement is incorrect regarding the diagnosis of vascular calcification? Lateral abdominal X-ray can help detecting vascular calcification. The CT allows for early risk stratification for a major adverse cardiac event. Kaplan score quantified the severity of lumbar aortic calcifications observed on a lateral abdominal radiograph. The Drago score quantifies calcification of the iliac, femoral, radial, and digital arteries observed on plain radiographs of the hands and pelvis. CT can detect vascular calcification and differentiates between intimal and medial calcium deposition. So what do you think? You can send your answers via the chat box. So if I'm going to answer this question, lateral abdominal X-ray can help detecting, yes, and the KDIGO guidelines recommend the lateral abdominal plain X-ray film for detection of vascular calcification. So as regards the X score, it quantifies coronary artery calcification and detected by cardiac CT scan and can allow early risk stratification for major adverse cardiac events. So as regards the option C, Capella score quantifies the severity of lumbar aortic calcification observed on lateral abdominal radiograph. This includes imaging from 10 thoracic 10 vertebrae to the first two sacral vertebrae. Both anterior and posterior parts of the aorta are analyzed, resulting in a final score between 0 and 24. So this option is right, or the structure is right. So regarding the Drago score, does it quantify calcification of iliac, femoral, radial, and digital arteries? The answer is yes, and can give a score between 0 and 8 points. So if we have a score more than or equal to 3, this means an almost fourfold higher risk of cardiovascular mortality. So you're right. The incorrect answer is E. Computed tomography can detect vascular calcification and differentiates between intimal and medial. It can, yes, detect, but cannot differentiate between intimal and medial calcium deposition. So the second question, which one of the following drugs used to treat osteoporosis is primarily a sclerostin inhibitor? Raloxifene, denosumab, risindronate, romosumab, odansitib. So what do you think? You can send your answer by the chat box. So, okay, raloxifene is a selective estrogen receptor modulator, which decreases the rate of bone loss, particularly shown in postmenopausal osteoporosis. Denosumab is a human monoclonal antibody against Schrank-Keller, and risindronate belongs to the bisphosphonate family with anti-osteoclast effect by inhibition of the enzyme tyrosine pyrophosphate synthase, which is responsible for the generation of isoprenoid lipids that is used for post-translational modifications of GTP binding proteins required for osteoclast viability and function. So yet we have D and E. Romosumab is a humanized monoclonal antibody to sclerostin, which is a sclerostin inhibitor, which targets Wnt signaling pathway and has been found to increase bone formation markers and decrease bone resorption markers, while odansitib is a cathepsin K inhibitor, which inhibits the resorptive activity of the osteoblast. So D is the right answer. So let us take a couple of questions. Question number 3. Which one of the following regarding management of osteoporosis in postmenopausal women is incorrect? A. Intravenous bisphosphonate can be used in women who are intolerant or on bisphosphonate. Teriparatide is preferentially recommended for patients at high risk of fracture. Long-term use of vitamin D derivatives is the safest and most efficient approach. Withdrawal of denosumab therapy is associated with a rebound in vertebral fracture rate. Repairing exercise forms an integral component of osteoporosis management. So what do you think is the right answer or the incorrect sentence among those? So if I'm going to choose the incorrect answer, it will be C. Long-term use of vitamin D derivatives is the safest and most efficient approach. Simply, this is because the long-term use of vitamin D derivatives is associated with high risk of hypercalcemia and hypercalciuria. And the adverse effects of hypercalcemia include impairment of renal function and nephrocalcinosis. So this narrow therapeutic window demonstrates frequent surplus of serum and possibly urine calcium in patients exposed to these agents. So yeah, IV bisphosphonate can be used in women who are intolerant to oral bisphosphonate. Teriparatide are recommended in patients at high risk of fracture. Withdrawal of denosumab sorabine may be associated with rebound risk of vertebral fracture. The weight-bearing exercise forms an integral component of osteoporosis management, but long-term use of vitamin D is not safe. So let us take the last question. Which one of the following regarding the pathogenetic role of microbiota in CKD-related vascular calcification is incorrect? Patients at any stage of CKD have substantial difference in gut microbiota composition compared to healthy individuals. P. Dysbiosis is more common in patients with advanced rather than early CKD. C. Vitamin K intoxication has been strongly associated with vascular calcification. D. Induxyl sulfate induces the expression of osteoclast-specific proteins and aortic wall calcification. And eventually, E. P-cresol sulfate may act as pro-osteogenic and pro-calcific toxin. So what do you think is the right answer? Which one is correct? So in CKD patients, there is augmented microbial production and increased intestinal permeability to not only the microbiomes, but also their products. This contribute to progressive accumulation of serum uremic toxin, particularly at advanced stages. Induxyl sulfate and P-cresol sulfate induce suppression of osteoclast-specific proteins and aortic wall calcification and sickening, and the long-term exposure to both significantly increase the calcification of aorta and peripheral arteries of CKD rats. On the other hand, vitamin K deficiency rather than intoxication has been associated with increased risk of vascular calcification, as a positive association has been found between vascular calcification and vitamin D deficiency, and vitamin K antagonists have been associated with increased risk of cardiovascular calcification and calciphylaxis. So the incorrect answer will be C. So this is just a sample multiple choice questions in the field of CKD-MBD in the second module topics. And you're going to get more and more questions in the course. And thank you.
Thank you so much, Dr. Rasha, for this demonstration. The next demonstration will be presented by Dr. Shaima Abdigilil. She will give us some highlights about the journal club, the articles that you are going to read and to learn from and to answer throughout the course. Go ahead, Shaima.
Thank you so much, Dr. Amr. Welcome, everyone. I'm so excited to be with you today. I'll talk about the journal club part of each week of the module. As we all know, journal club is very important for medical education. As it helps keeping up to date with recent studies, developing critical appraisal skills, it has an impact on clinical practice, and it improves the knowledge of care research and also provide a space for discussion. So we were very keen to choose the most updated, well-written manuscripts with properly conducted studies to cover all the topics of the program. For each week of the program, you will find one, sometimes two, well-chosen state-of-art manuscript to expand your knowledge After that, you will have the chance to test this knowledge by answering the questions we prepared for the manuscript. There will be a continuous communication with the tutors who will be available to answer your questions and to address your concern. For further reading, we added other valuable manuscripts to a supplementary file. They will be available for you to read and to download by just a click. For example, as you see at week 3 of this module, we will study a very important topic we deal with all the time in our clinical practice, the osteoporosis. As you all know, so far there is no consensus regarding the treatment of CKD-MBD, especially in pre-dialysis patients. So the European CKD-MBD working group tried to come up in this article with such a consensus. This article, the European Consensus Statement on the Diagnosis and the Management of Osteoporosis in Chronic Kidney Disease Stage G4 to 5D, was published at Nephrology, Dialysis and the Transplantation Journal 2021. And this journal has one of the highest impact factors in nephrology. And as you also notice, the first author in this manuscript is Dr. Peter Evenpool, one of the leaders in nephrology and CKD-MBD area. So try to read these articles to answer these very important questions. First question. Yes. First question, identify the best anti-osteoporotic medications for treatment of patients with CKD and low turnover bone disease. Second question, illustrate the role of bisphosphonate as a therapy for treatment of osteoporosis in patients with CKD with determination of its medical concern. Third question, regarding denosumab, identify mechanism of action, indications, medical concern, and its relationship with vascular calcification. And the last question, appraise the use of selective estrogen receptor modulators, the SERM, in treatment of patients with CKD. These questions will cover all the topic. Again, try to enjoy answering these questions and also learn, and thank you.
Thank you so much, Shaima, for this illustration. The next demonstration will be presented by Dr. Shuru El-Naggar. She will give us some heads up about the clinical case scenarios. So as we mentioned, every week, you will have at least a couple of clinical case scenarios. They are mostly real cases. Sometimes they are virtual. And it will help you how to, in a real time, manage this complicated cases. So go ahead, Shuruk, and show us what you are going to teach us today.
Thank you, Dr. Am. Our CKD-MBD graduate certificate program includes 12 weeks per module. Every week has a different topic, including clinically relevant journal clubs and multiple choice questions. It also comprises multiple clinical case scenarios with informed explanations. Clinical case scenarios are provided with detailed clinical and laboratory data to help you to test your knowledge with open and interactive discussion with your tutors, discussing approach and management plan with. This is an example of a clinical case scenario about calciflexes and cardiovascular calcification in CKD. A 56-year-old male patient with hypertension for the past 10 years, history of end-stage renal disease 2 years ago. The patient is maintained on chronic hemodialysis 6 sessions per week. In the past 2 months, the patient presented with progressive hemorrhagic tender lower limb lesion with central necrosis. His past medical history include idiopathic pulmonary arterial hypertension on epoxydenol and warfarin. Other medications include calcium acetate and alpha-calcidone. Laboratory investigation of this patient is demonstrated in this table. The patient has reduced intact PTH below the recommended target level for patient with end-stage renal disease, and inadequate dialysis revealed by a reduced urea reduction ratio. This is skin biopsy revealing vancosa stain, which show calcification in the media of the wall of this subcutaneous blood vessel and intraluminal thrombus. Interpret the patient's laboratory investigation, suggest a possible management plan for the patient's current condition. Please feel free to respond and share your ideas in the chat box. The patient was diagnosed to have calciflaxis. Patient was started on sodium thiosulfate treatment, 25 milligram by the end of each dialysis session intravenously, and warfarin was switched to new oral anticoagulant. 3 days after starting sodium thiosulfate treatment, the patient developed respiratory distress, tachypnea, followed by generalized seizures. Laboratory investigations at this stage is shown in this table, with increase in serum sodium from 130 to 140 and reduced level of serum bicarbonate, which was 11 milliequivalent per liter. Define the acid-base disturbance in this patient. Mention the main lines of treatment for the current patient's condition. Would you restart sodium thiosulfate therapy for the residual lower limb lesions after improvement of the acid-base disturbance in this patient? You can send your answers in the chat box. Calciflaxis. Calciflaxis is potentially life-threatening condition that occur in renal and non-renal patients characterized by skin ischemia and necrosis, occurring mainly due to calcification of cutaneous cells and villi. This disease carries a high morbidity and mortality. According to the literatures, about half of these patients may die within 6 months of diagnosis. Pathogenesis of calciflaxis include calcification and fibrosis and thrombosis of subcutaneous arterioles, leading to reduction in the arteriolar blood flow, and finally skin necrosis and ulceration. As we can see, this graph shows a normal artery and then calcification occurring in the media of the wall of the blood vessel, followed by fibrosis in the underlying intima, and lastly, intraluminal thrombus. Calciflaxis is characterized by microvascular calcification and thrombosis. Thrombosis in calciflaxis is mainly predisposed by systemic or local hypercoagulability, while microvascular calcification is predisposed by suppression of calcification inhibitors and stimulation of calcification promoters. Risk factors for calciflaxis include hyperphosphatemia, hypoparathyroidism, drugs like warfarin, calcium-based phosphate binders, vitamin D analogs, female sex, obesity, hypercoagulable status, hypoalbuminemia, diabetes, longer dialysis vintage, inflammatory and autoimmune disease like systemic lupus erythematosus, and lastly, iron administration. Diagnosis of calciflaxis is mainly clinical, depending on recognition of the characteristic skin lesions of calciflaxis. However, if the patient has atypical features of the skin lesions, or if the patient is candidate for experimental therapy, percutaneous skin biopsy should be performed. Despite this simple algorithm, it is important to know how to clinical situations which resemble cassiflexes or what is called cassiflexes mimickers, and this will be discussed in cassiflexes section in our module 2. Management of cassiflexes include wound care and pain management, management of infected wound using antimicrobial therapy and surgical debridement, control of hyperphosphatemia and hyperparasitis using non-calcium containing phosphate binders, citric acid, and dialysis optimization. Lastly, adjusting medications with a storage of vitamin D, calcium supplement, warfarin, and iron, and starting sodium thiosulfate therapy. Evidence supporting use of sodium thiosulfate in cassiflexes is extrapolated from in vitro study, case series, and retrospective studies. On the other hand, meta-analysis of data from retrospective studies reported no difference in the risk of mortality, wound or amputation between patient treated and patient not treated with sodium thiosulfate. Despite that, meta-analysis represents a higher level of evidence than case series and retrospective studies. In cassiflexes section, we will have scrutinized appraisal for these data to make sure that our patient will not miss any chance to heal. Sodium thiosulfate should be given intravenously. The dose is adjusted according to body weight. If the patient weight is less than 60 kilograms, the dose should be 12.5 milligram, and if the patient weight is above 60 kilograms, the dose should be 25 milligram. We will also learn how to tailor the therapeutic regimen according to the stage of chronic kidney disease and according to the modality of renal replacement therapy in patients with end-stage renal disease. Side effects of sodium thiosulfate include high anion gap metabolic acidosis, which occur in 1/3 of patients, and was the clue for our case scenario and was responsible for the fits and respiratory symptoms in our case. Other side effects include nausea, vomiting, volume overload, hypocalcemia, and increased propensity for skeletal fractures with prolonged use. Patients on sodium thiosulfate therapy should be monitored weekly by serum calcium, phosphate, bicarbonate, anion gap, and white cell count. If the patient has mild side effects, we should decrease the dose and increase the duration of infusion of sodium thiosulfate. And if the patient has intractable side effects despite medical treatment, we should discontinue sodium thiosulfate therapy. However, after improvement of these intractable side effects, would you recommend restarting sodium thiosulfate again in these patients? And what about other novel experimental therapies for cassiflexes like vitamin K1, hyperbaric oxygen, tissue plasminogen activators, and larval wound therapy? Exclusion of disease mimickers and tailoring therapeutic regimens according to different patients' characteristics, tuning of treatment plan according to patient response and occurrence of adverse effects, and increasing your knowledge about updated and novel experimental therapies, all are targets of our case scenarios in Module 2. Thank you.
Thank you so much, Dr. Shuro, for this amazing presentation. The next thing I'm going to show you for the CKD-MBD Module 2 is the handbook. And I'm telling you that you should receive this handbook in your email and also probably in the WhatsApp group. So make sure that if you don't receive it within a week, the handbook, and also if you participated in Module 1, you should have your username and the password. If you are new to the program, if your first module is Module 2, if you didn't finish Module 1, if you didn't participate in Module 1, and you don't have access to the platform, you should receive a username and a password within a week, because we are going to start our CKD-MBD Module 2 in July 1st, as we discussed. So if you don't get this handbook, or if you don't have an access to the platform, having username and password, please contact us. We already created a WhatsApp group for participants of Module 2. So if you don't receive any communication from us, this means that you are missed in our communication, and let us know, please. Here is the handbook of the program that include all the details about this program. So it includes an introduction about the World Kidney Academy. It includes a statement from the program director. It includes the communication between the students and the program and module leads. It includes details about the LMS, the Learning Management System, the platform that we are going to use, how to communicate with the technical, the IT person. We have Ahmed Magdi with us today. So if you have any technical issue, you can contact him. He will be also included with us in the WhatsApp group. And how to contact Buran and Norhan, our administrative section, if you have any problem regarding any administration, registration, payment, or anything like that. In the handbook, you will see details about students' admission, cost information, patient anonymity, accreditation, the course directors, program directors, and academic lead, and program convener and liaison, the academic lead, the board directors, the module leads and co-leads, the international guest speaker, the international partnership with different organizations, the structure of the program, and also you will see the board of examiners, the board of directors, and more importantly, you will see the syllabus and the timetable. And I'll take you over here. So all of these details, you can go over it. We'll send you the handbook, but the most important section is this, the syllabus. This is for Module 1, and the syllabus, the timetable also for Module 1. Then here we are going to focus in a couple minutes about Module 2 syllabus. So we have 9 weeks of education. Probably they are going to be extended a little bit to a couple weeks more because of the holidays. So Module 2 will start with osteoporosis. First week will be introduction, definition, and diagnosis. Second week will be will focus on bone quality and quantity in CKD patients. Then the third week we'll talk about pharmacological and non-pharmacological intervention for the osteoporosis management in our CKD patients. So these are 3 weeks. Then we'll focus on radiological changes and post-transplant bone disease for 2 weeks. Then we are going to focus on cardiovascular calcification in another 2 weeks. Then we'll talk about guidelines and up-to-date management of CKD-MBD. And we'll finish by lecture about parathyroidectomy and a week of surgical management of intractable, refractory, resistant, secondary, or tertiary hyperparathyroidism. Here is a timetable. So week 1, 2, 3, up to week 9. So this is what you expect to get throughout the course. For the sake of the time, I'll stop by here. This is everything that we want you to know about our program. And I will open the floor for any questions, comments, concerns, and discussion for a minute. So if you want to talk, or if you want to share your ideas or comments or concerns or questions in the chat box, please feel free to do that. Dr. Ibrahim Omar is asking about the certificate of Module 1. So to get the American Association of CME accredited certification, you need to finish the whole program, which is Module 1 and Module 2. If you pass Module 1, you will receive a certificate of passing Module 1, but this is not a certificate of finalizing and graduating in the program. To be graduated and to receive a certificate of graduation, you need to finish the 2 modules. So before the end of this week, before starting, the Module 2 in July 1st, the participant who passed the Module 1 will receive a transcript showing them that they already passed Module 1. But again, for the accreditation and for the final program certificate, you need to finalize and to finish and to pass both Module 1 and Module 2. It doesn't matter which one you start first. They are independent, so you can start with Module 1 or Module 2, but to receive the certificate, the final certificate, and the accreditation, you need to finalize both modules. Yes, Dr. Faisal Shaheen is asking if someone just joined, how can finish Module 1? So after finishing Module 2, he or she will have a chance to participate and to register to Module 1. Then again, this will be going on after finishing Module 1, start Module 2, then again, we'll do Module 1. So it's CME, it's continuous medical education, so it shouldn't be a problem. Thank you, Dr. Faisal, for your question. Thanks, Ibrahim Omar, for the question. Yeah, if we don't have any further question, I think we need to finish now. And I wish you the best and thank you for participation. We are going to post the recorded video of this induction meeting on the social media. So please feel free to share it with others who didn't have a chance to attend the meeting today. Thank you, everyone, and happy holiday. Bye.